is the patient who may present quite late because they're fairly well balanced if no one's listening to their cardiac examination because they have a loud pulmonary stenosis grade murmur. In congenitally corrected transposition, what happens is you have each great vessel arising off the inappropriate ventricle, but the ventricles are also discordant, right? So you have atrioventricular discordance and ventricular arterial discordance, resulting in normal saturations and normal flow pathways of your oxygenated and deoxygenated blood. So the atria is in the usual position, the ventricles are reversed, your tricuspid valve is your systemic AV valve, and this is also the names, okay? It's known as double discordant transposition, SLL transposition, L transposition, congenitally corrected transposition, has more names than it really is worthy of. And you have the same variable physiology. So you have VSD, VSD and PS, and VSD and bad PS. All right, and in these, you kind of have the same situations. With this, you might have more systemic AV valve regurgitation when you have increased pulmonary blood flow because of that really unworthy tricuspid valve, right? It's not really worthy of the systemic pressures. It really can't handle it, and it can't handle the volume load on top of that. So you can get bad AV valve regurgitation that doesn't resolve after closing this VSD. All right, now this might be a patient who presents later in life, but what about the simple L-transposed heart? Remember, we said they don't have any overt symptoms or murmurs or anything, so these are the ones that may present later in life, and we're talking 40s and 50s before they even have any symptoms, most commonly, if they have no associated features. So let's look at the transthoracic echo features of these patients. So this is a patient with a congenitally corrected transposition, and here we see a moderator band on the patient's right side. We see the tricuspid valve with its apical displacement. This is a normally apically displaced tricuspid valve. As we know, they can have much more pronounced apical displacement and have an increased regurgitation in those settings. All right, and in here, as we come more anterior, the first vessel we encounter is the pulmonary artery. Here we see it's bifurcating. So the pulmonary artery is posterior and coming off that morphologic LV, and then coming a little bit more anteriorly, we see the aorta anterior and leftward. That's often sometimes your first clue that you have an L transposition is that the aorta is anterior and leftward, which it never is in almost any other case. What are associated malformations in the non-square diagram? Here we have about 70% of patients with LTGA have a VSD. Here we see this in what looks like the posterior membranous septum. They're often perimembranous or perimembranous to muscular. They can extend into the inlet region, and they can also have associated muscular defects as well. Here's another patient with